Thank you, Dr. Aneja, and thank you, Dr. Fuchs. We've heard, I think, about digital pathology and digital radiology long before other digital solutions in medicine, and I think many physicians and patients too will be comforted by your remarks that these tools aren't going to replace doctors. You made it very clear that physicians are involved in choosing the right clinical questions, physicians are involved in training the tools, and that these can only augment clinical decision-making. I think one of the themes from this conference that we're going to hear, Dr. Levy already referred to, these are part of an ecosystem. We're not relying just on one tool. So I'd like to ask you both a question about combining digital radiology and digital pathology. Can we use the proteomic and genomic information we get from digital pathology in combination with the vascular and structural information we get from digital radiology and come up with a better solution? I'll start with Dr. Fuchs and then Dr. Aneja.
Thank you. Thank you for the invitation again, and thank you for the question. The answer is, of course. Technically, it makes a lot of sense to build multimodal approaches, not only radiology and pathology, but of course, all kinds of molecular approaches or clinical variables. The practical hurdle is that the more modalities you add, the smaller the data sets usually get. Most of the machine learning techniques we use these days, especially the deep learning based one, need a sizable set of patients to produce models that are clinically stable. And I think that's one of the reasons that hold us back in that regard. That at least even from our experience at Memorial, as soon as we combine radiology and pathology, the data sets get much smaller. But scientifically, of course, it's shown multiple times, also from our group, that you can gain by combining modalities, and the future will certainly be a multimodal approach.
Dr. Aneja.
Yeah, I completely agree with what Thomas mentioned. The idea behind it is actually very sound, but the difficulty is actually more administrative because of the siloing of data across different departments and different institutions. I think the other piece that's difficult, oftentimes people ask about integrating clinical information. One part that we have not figured out exactly is, yes, if we have a data set and we have clinical variables, it tends to make the data model better. But the problem is that we oftentimes in these image analysis studies do data augmentation, where we manipulate the image in order to artificially sort of increase our data set size. And there's not really a sound way in which we can actually do that with the clinical variables. And so then it ends up becoming a little bit biased in that way. And so sometimes some of the data streams don't actually, some of the methods that we can do to sort of make our models more robust in image analysis path or radiology, you can't actually apply those to clinical variables as easily.
Thank you. I'd like to ask you both another question for each of you. Are you able to make any research or policy suggestions that would augment or implement, help your work move forward? After all, this is the National Cancer Policy Forum. We'd like to help. Dr. Aneja.
Sure. So I think that a lot of the work that we're interested in on the mathematical side is actually very much in addressing those issues. I think interpretability is a huge piece of it. I think that Thomas would probably agree with me that if you really read the literature, there's so many ROC curves that are like almost perfect that are published, and then you wonder whether or not the models are overfitting. And so I think a lot of times with image analysis, you want to make sure that you're looking at the right thing. So I think having certain benchmarks of what is necessary before we actually implement something or move it forward towards a regulatory or a clinical product is kind of important. We think in image analysis, interpretability pieces like image, understanding exactly what parts of the image are the most important in developing a prediction are very important. Also, I think that appreciating the generalizability and the performance loss as you transition your data set to another source is important as well. There's always a little bit of performance loss when you move from one institution to another, and understanding that performance loss is important and trying to better quantify that as well.
Thank you. Dr. Fuchs.
Yeah, I couldn't agree more with everything Sanjay said. We have one advantage regarding interpretability with these models, although they are very complex. They are actually not black boxes, right? You can investigate them. You can investigate every single neuron, every single parameter. You couldn't do that with a human, for example. So if you talk also about biases, for example, mathematical biases, social biases, that's something that can be corrected in models. It's much more difficult to correct biases in humans. And regarding the performance, I completely agree. The key is not only multi-institutional, but very often also multi-country or continent to really see broad performance across all kinds of situations, wet labs, histology labs, radiology labs, and so forth, to exclude all kinds of technical biases. And I think one thing we certainly should all be aware of is that at the end of the day, there won't be hundreds of applications, for example, in pathology, where pathologists can pick and choose, or thousands, or app stores or these kinds of things. Because getting an algorithm or an AI through a regulatory process with the FDA, especially if it's diagnostic, is tremendously difficult. So, for example, in pathology, there's not a single FDA-cleared algorithm today. And that's okay, because that's the FDA's responsibility to make sure that these things truly work. The last thing anybody wants in our field is that physicians get flooded with tools that don't work, and then there's loss of trust and so forth. So at the end of the day, there will be a small set of algorithms that truly perform and that get IVD or FDA approval.
Thank you, Dr. Fuchs. You commented on the democratization of pathology by providing tools that level the abilities across institution. Is there also and also you spoke about the tremendous workload and pressure pathologists in an individual institution are under. Is there any possibility of distributed pathology, second opinions in other communities, anything that would speak to the COVID challenges or other availability beyond the medical centers for high quality pathology?
So very much so. So these are a little bit different questions. So regarding tailored pathology, that's a digital pathology question. So as soon as you are digital and digitized, pathologists could look at it from all kinds of places. In the US, that's also regulated by the FDA. So you cannot use every viewer with every scanner, but there were emergency authorizations for COVID, which of course makes a lot of sense. So you don't put the pathologists at risk for going into the hospital, and they can sign out from home. There's a push in that direction, and I think that is very good. I don't think that somebody would disagree with that. That does not reduce the workload, though, and the workload of pathologists will significantly increase in the future. It's not only that there are more cancer cases which are more complex. Think of liquid biopsy. As soon as that's used for screening, there are going to be so many more biopsies afterwards, which lead to even more workload for the few pathologists left. So you will need these kinds of tools just to keep the standard of care. Of course, the promise to do much more, because you could predict, for example, the potential for example, mutations or TMB or MSI or other things pathologists couldn't see with their eye. And so it enriches also their work. But first of all, it should help them to go through that enormous workload. And that's true for the rest of the world even more so, right? In the US, we are blessed with a decent number of pathologists per 100,000 people. In Europe, it's worse already, also in Austria, where I'm from originally. But if you look into the developing world, in Africa, it's really problematic. All of Uganda has one pathologist. So there is not even a pathologist who could take over. So there you need these tools to also enable nurses or MTAs to at least do some basic work for the benefit of the patient.
Thank you. One last question for Dr. Aneja, and then we'll go back to Dr. Estrin. In terms of digital radiology, is the equipment or the physician and technician training the bigger lift?
So I think that all those technical challenges actually do have to be accounted for. So the equipment, the different imaging parameters is actually something that's really important. And I think that it's something that we constantly have to deal with. And I think that's why it's important that clinicians or radiologists or people who are well-versed in diagnostic radiology and the little differences between different CT scanners and different MRI scanners are involved in every step of the process. And this is the reason why I don't think that, like a tech company that doesn't have necessarily clinicians who are very involved is going to be the ones who solve this. I think it's going to be clinicians who actually understand the little intricacies. With respect to technician pieces, I think that there's two pieces to that. One is it's very difficult to account for that mathematically. So it actually requires us to just develop a robust test set or a training set where we actually account for all those different parameters associated with poor imaging and good imaging. And so I do feel like that is something that's probably the harder part. And like Thomas mentioned, it's easier for us to fix some errors with AI, but human error is extremely difficult to fix. And so I think that that's the part that actually is a little bit more difficult to fix.
All right. Well, thank you to Dr. Aneja and Dr. Fuchs for adding so much to our workshop. And back to you, Dr. Estrin.